Thank you. Welcome. Today is March 11, and March is Colon Cancer Awareness Month. It is Colorectal Cancer, CRC. And I welcome you all on this Saturday, either it's morning or evening, based on the time zone we are in across the globe. And the session is recorded so that we can spread the word afterwards also to so that more and more people learn about the screening, the treatment modalities, and also beyond, the survivorship, or how we can work with the managing the colorectal cancer scenario. So little bit about how we started the CRC Hub. And it's all because of Ravina Kashyap, who is one of our speakers here. So it was in 2019, and like Ravina, I think it was your initiative that we started the CRC Hub, and in your honor. So I cannot be more grateful to you for being the inspiration behind the CRC Hub, which is the BCH Wing. And we would love to hear from you a little later. But before that, I just want to give a brief about our organization, so Breast Cancer Hub. So I'm Lopa, I'm the founder, and I started BCH in 2017. I was a cancer research professor at University UNCC, specialized in breast and pancreatic cancer. But in 2017, I resigned from my career to start BCH as a full-time voluntary service to bridge the gap between the developed and developing countries, so that we can work towards because the main reasons why the late detection happens is because of lack of awareness, because of the taboo, ignorance, leading to late detection, inaccessibility to healthcare facilities, proper treatment management and guidance. So all these concerns motivated me to start this, and then beautiful souls joined in, and that's how our organization has grown over the years. It's been more than 5 years now. So what we do, so of course we do the community outreaches, and I started off with breast cancer in 2018, doing the community outreaches in the developing world and also in the US. But also we developed especially the breast self exam cards for the first time for her and him, and we have it in 24 languages and all translated by our volunteers, because we are more like those who live here. We are a volunteer driven organization. And so then when we did this, the reason was that so that we can tap the untapped sectors, we can work in the local languages, but also taking accountability. So everyone has my WhatsApp number, my email address. So anyone having any concerns can reach out to me, and I try to guide, navigate, analyze the reports, and help in every direction. But then in those directions also, we started to build our support group, which is a virtual WhatsApp group, which is a very private group where I always say that 95% of our work we never publish anywhere because of the patient privacy. So that's where I met Dr. Raghava in Charlotte because of another event, but that's how he joined in, and he is a super what do I say, a strength to our BCH support group. And he is one of our main, tech speakers, who is an oncologist. He is the only oncologist speaker here, and we can't wait to hear from you from the technical aspects of colon cancer, CRC. Now, coming back to this, so in addition to our support group, we also have adopted villages in India, in Assam. So we started off in Assam, and from one village now we have 16 villages adopted, and this started in 2020 in February, right before, during the COVID, I would say. And that was the time my dad passed away in 2020, February 22nd. And after that, in 4 days, we started this. And this, I owe it to Sanalambi Devi. I'm sure she's here. She's the project coordinator, and also our team in the villages. I mean, such a wonderful team. And that's the team who we have, I think, more than 12,000 villagers we have screened. But then the challenges that we faced were during the COVID time, then there were no one to take them to the hospitals. And so we take care end to end, door to door screening, then also taking the suspicious cases to the hospital, then providing the initial treatment aid, which is not covered by the local hospital. But we usually collaborate with the local cancer hospitals who serve the underprivileged. For example, in Assam, we collaborate with Kacha Cancer Hospital, and the director is Padma Shri Dr. Ravi Kannan. Then also the Silchar Medical College, who provide more free treatment, but a lot of hiccups are there, which we try to manage, and then we bring the patient back to their home. We do follow-up counseling. So basically, beautifully taking care end to end. That is what we do. And from Assam, now we have moved to West Bengal too. Like in Assam, of course, in addition, we are expanding. But in West Bengal, different villages. In Nadia district, we have adopted 2 villages, and we have the project coordinator here too today. So we are like this, we recently started. And also now, we are going to start in Tamil Nadu in the Tiruvalla district. So that's how the villages adoption has been going on. But in addition to that, of course, in the US, we have done plenty of community outreaches. We have the students who are the torch leaders. I do the mentorship sessions, and it's more like leadership for them, but they learn to give back to the community in a very meaningful way so that they can spread the word in their community. So, and then also we have the patient treatment aid for the underprivileged. I'm not going into the detail, but we do a lot of research at the grassroots. Our research is IRB USA approved and IC Ethics Committee India approved, so that now the research is more towards changing the healthcare policies, so that we can help with the scenario, like at the grassroots level. What is the real scenario with the cancer awareness standpoint, and also the retrospective? What are the different factors? We do a lot of clinical data analysis. In addition, most importantly, in Charlotte and in the USA, we have started the patient care package, which we recently started last 1 year. So we have developed specialized pillow with a pocket, which we can put the heating pad or the ice pack in there, so that it becomes very easy, very comforting for during the healing process, post-surgery, lumpectomy or mastectomy. We have also developed chemoport seat belt pillows, so that it's comforting for our patients who have the port. And also we have the chemo head. So these are the packages that we have built recently, and that's also because of beautiful soul reaching out to me, who said they want to stitch for Breast Cancer Hub voluntary. So that's the beauty of our organization, and that's how we function. And there are many other programs. Please go through breastcancerhub.org. I'm not able to do justice to the work that we have been doing, but one thing is for sure, that is the relationship that counts for us. And we become one family eventually, as we grow. And I have Krishna here, and I have Uma ma'am here, I have Dr. Neetu. So, we start connecting because of the word cancer, but then finally, it becomes like a lifelong relationship, and that's who we are. So forgot to mention an important thing. 100% of BCH services are free. So we do everything free, and all donations are driven towards our mission. So saying that, I would like to invite our first speaker, Ravina Kashyap. I don't think anyone needs introduction about her. I've already said the CRC hub, the colon cancer hub, is in Ravina's honor, and she's an inspiration for our community. And because of Ravina, she initiated the BCH meditation circle, and she has been doing this because she's going to speak about that, tap into that also, why it's important. And Ravina is her professional. Little bit about her, she is a meditation practitioner, as I said just now. She also works at Truist Bank at digital banking. So even though she's super busy with her full-time job, but still she manages to give back to the community by advocating for colorectal cancer. And Ravina is a stage 4 CRC, colorectal cancer advocate. So over to you, Ravina, and I'm so honored to have you. And yes, the platform is all yours. And I welcome you on behalf of Ravina and me to this webinar today.
Thank you, Lopa, and thank you for all your kind words and for all that you do. It is just beyond comprehension that where you have reached in these 5 years and brought Breast Cancer Hub and all its various wings for all the different types of cancers. So just there's not enough words to even mention that, what all that you have done. But going into this, hello, and a very good Saturday morning and Saturday evening to all of you from all around the globe. Firstly, I have to thank every one of you. I know everyone has very busy schedules, so I am glad that you are able to attend this webinar today. As many of us know, March is dedicated to colorectal cancer, and for me, it holds a very special place in my heart because I am a stage 4 colon cancer survivor, and I have been in remission for 5 years. I just completed 5 years of remission in February and got a clean chit of health from my oncologist. So anyway, let me briefly tell you about my battle with colon cancer. I was 44 years old in 2014 when I was diagnosed. I had been undergoing lots of abdominal issues. I missed totally the blood in the stools, which is one of the biggest symptoms of many abdominal cancers, but I totally missed that part. But I was going through a lot of abdominal issues. I was unable to, eat right, unable to keep my food down, and I was losing weight very rapidly. But no one who has no family history would ever think of the word cancer. And it was the same for me. In the back of my head, I knew something was seriously wrong. But again, I would never think that it would be cancer. I was totally ignorant, like many of us are, and we like to stay away from the C word. And I would run a mile, of course, if I were to hear that word. Anyway, who would have thought that I would be yet here? When I celebrated my 50th birthday, I was truly thankful, and I'm always grateful for the same. Anyway, for the next 3 to 4 years, I had 2 more relapses as I underwent bouts of having my colon surgery in 2014, followed by 6 months, which was 6 months of chemotherapy, and every 2 weeks, and then they actually ruled me as cancer-free, only to know that about a year and a half down the line, I was staged at stage 4 when they found 2 spots in my left lung wall, and of course, on biopsy, they found out that it was colorectal cancer, and it had spread. So I went through some more chemotherapy and then radiation, and this happened twice. And so I was constantly battling for the next 3 to 4 years. During that time, I had the good fortune to be introduced by a dear friend to Lopa. So I think Lopa, we were introduced in 2018 or 2017.
2018, I think, yes, by Amrita, yes.
Yes,
Amrita.
by Amrita.
Yes.
So and of course, Lopa has turned out to be a very dear friend over the years. And then after several talks over time, we decided to add the colon cancer wing to breast cancer hub. I'm not sure, but probably that was one of the first.
Yes, that was the first one. Yes, in 2019.
Right, and I willingly agreed to be an advocate for CRC. Over the years, I realized how important it has been and continues to be when I have, to dedicate myself as an advocate for colorectal cancer. As in all cancers of the abdomen, many people get diagnosed in later stages of cancer rather than earlier. This is mainly due to the fact that we shrug off the symptoms, and by thinking of it as acidity or hemorrhoids or gastric issues. Little realizing that when we have prolonged symptoms like blood in your stools, being anemic, painful stools or just pain in the abdominal region, extreme fatigue, and of course, rapid loss of weight. These are symptoms to always look out for and to pay attention to your gut and take action, go and get yourself checked out. As many of us, we prolong this, we do not pay attention to ourselves. And, sometimes we just don't even realize till we are in later stages. In 2014, the permitted age for a colonoscopy to be scheduled was 50. And as many of us might know, I'm glad to inform you that now it is 25 in the United States. So, which is great, because when I was diagnosed, my doctors were, they were they just could not figure out why I got this cancer at the age of 44 without any family history or any history of any kind. So my request for everyone, each of us who are over the ages of 45 and or experiencing any of the symptoms that I mentioned above, please call your doctors, be your own best health advocate, and schedule your colonoscopy that your insurance is going to pay for if you are over 45 and that you rightfully deserve to do. Another way to safely, and just do it in a very, private manner is Cologuard. It is an at-home screening that is very effective and will be discussed more as we go along today. During my treatment, I did get a lot of time to myself and watch the world go by. It took a long time for me to understand and accept that fact and that reality that nothing stops in this world. I began to go inwards and got more in touch with my spirituality. I began to meditate and got certified as a Reiki master. I realized that I have healed by helping others heal. And with Lopa's help, I initiated the Chakra Healing Group. And we also have the Breast Cancer Hub Meditation Circle. Please reach out to either Lopa or me anytime if any of you would like to join this totally free service and meditation group. I would be honored. On that note, I would like to end with saying, please do not ignore the signs and symptoms and always get scoped. And in a nutshell, I would just like to say, be your own health advocate, and awareness is the key, not ignorance. I know most of us would not like to deal or talk with the word cancer, but being aware is the winning card. I would like to again thank Dr. Lopa for giving us this platform, for bringing us from all different parts of the world closer together, as I hand this over to Dr. Raghava to share his words of wisdom.
Thank you. Thank you so much, Ravina. It was so inspiring and advocating for the early screening, and nothing better than that, right? And it was really, really great talk, so articulated, covering all the different aspects of your journey and also translating towards early detection and an arch to our community. Thank you so much, Ravina.
Thank you, Lopa. I mean, we could go on and on with this, but just trying to put it all in a nutshell, and just hoping to reach out to anyone. I'm always here anytime if you need to reach out to me. So
absolutely. Yeah. And I know you have always been there. And I just wanted to mention, thank you, Kremilda, who has joined in from Sierra Leone. And so, that's how we have been working in Africa, especially in Sierra Leone, collaborating with Thinking Pink Foundation. And so I'm so glad that this message is going to reach over there too in her group through Kramilda, who is here. Thank you, Kramilda, for joining in. Now, with a lot of I don't know how to introduce Dr. Raghava. He is someone who has always been a pillar for the Breast Cancer Hub, and from day one, since we started our support group, and jumping in to give the advice to our patients whenever they have questions in our support group. So that is his introduction on a humanitarian ground. You know what he does, and of course, everything is selflessly. Now, professionally, Dr. Raghava Reddy Induru, I welcome you today as one of our esteemed speaker. He is a staff physician, medical oncologist at Levine Cancer Institute. He is the director of operations, Northern Region of LCI. And also he is the recipient of Dr. Chandrasekhar Das Memorial Award in 2022 on behalf of Breast Cancer Hub for his service to the community, to our BCH patients over the years. So without further delay, the platform is all yours, Dr. Raghava.
Thank you, Lopa. That was a very kind introduction. And what we do is a very small compared to the magnanimous amount of work that you do running the Breast Cancer Hub. And also thanking Ravina for, it takes a lot of courage and humbleness to share your story. And I think that was really important for everyone to listen to hear directly from Ravina. Thank you. And in the interest of time as well, the colorectal cancer can be a very, very extensive topic, and we'll try to focus on what's practical and what's necessary and what's important for the health of the community. I don't think it's moving. Okay. Did it go to the next slide?
Yes, it did.
Okay, perfect. So I think before we understand or delve into the depth of colorectal cancer, I think it's important to understand what is cancer. I mean, like, why do we get cancer and how does that happen? I'm always a person who try to keep things very simple. I think the simplicity really helps us to remind ourselves of our knowledge, our information, and how to make decisions. So cancer is not something that we acquire from elsewhere. It's our own body. It's the changes that happen in our body. It really comes back to a way to define at a molecular level, how does this cancer happen? So there are three parts to it: an oncogene, a tumor suppressor gene, and a DNA repair gene. So we have trillions of cells in our body, which is very important to the harmony of our body, how it works, how it functions, and how it changes itself as we live on through different decades of life. So oncogenes, they're not necessarily cancer-causing genes, but they're more of the genes that defines how to progress a cell and multiply a cell. So as our cells age and die, or they get injured and they die, how the new cells can come back and to do their job. Those are the oncogenes. They help basically the cells to multiply and function. The tumor suppressor genes these are the genes in our body that tries to tell the cell, okay, you have reached your lifespan now. I think we need to fade you. We need new cells to come back. So these are the genes that help to regulate those cells so they're not over multiplying themselves. DNA repair genes. So these are the genes where every time a new cell forms, the same genetic material has to transfer to the new cell, which is a very complex mechanism by which that happens. So because it's very complex, all the finer things have to align. If there is any kind of a mismatch that happens, it's the DNA repair genes which actually come and fix those, so that way that cell either is fit for survival or not fit for survival. If I have to take an analogy of a car, oncogenes are like our accelerator, Tumor suppressor genes are like our brakes. We need both of them, but not at the same time, nor they can be by themselves be active. They have to complement each other. The DNA repair genes are more like our mechanics, our toolbox, where if there's a problem, how we can fix those problems. I think this is really critical to understand before we understand anything beyond that. So colon itself. So we have our gastrointestinal system. We start with esophagus, where the food travels first, enters into the stomach, and from the stomach, the food starts its digestive process. It transpires to a small intestine, which is a long, thin-looking intestine that coils around in the belly. That moves on to a large intestine, where you have an ascending. Ascending means something that goes up the belly, that bridges the belly, which is the transverse colon, that comes down, which is called the descending, and something called a sigmoid, which is like an S shape, and something called a rectum, where the stool is stored. So what's the process or what's the function of this whole intestine is to absorb the water, salt, and the important ingredients that we need to function our body. So this process is important. And on the right of the picture, you can see how intricate our mucosa is, how intricate the wall of that colon is, how many layers it has, and how each layer functions a certain way to help with our normal daily metabolism. This is simply at a glance, just to understand how does the colorectal cancer work. So more than 90% of the colon cancers happen in people of age 50 or older. The incidence is more common in men than women, but the incidence certainly is much more in the African-American population than whites, and including the outcomes are very much negatively impacted in the minority population, especially the African-Americans, because the biology of the disease tends to be different as well. And catching the colorectal cancer early is important. I think Ravina emphasized to that point. 9 out of 10 individuals who are diagnosed with the early stage colorectal which has not spread, has a much more chances of survival beyond 5 years than patients who present with stage 4 lung cancer. Ravina is one of those 10% of the people who really beat the odds. And that's not something we can bank on every time. So only 1 out of 10 individuals with advanced stage colorectal cancer actually survives beyond 5 years. How many cancers are diagnosed in a year? Almost 150,000 of the Americans are diagnosed. Again, we don't have very clear statistics in countries like, for example, India or Africa or rest of the parts of the Asia. We just don't have enough data to understand what is the incidence of this colon cancer in that population. We'll talk about the warning signs in a moment. Some of the key facts to understand: incidence, young versus old. We always have that feeling that I'm younger, I'm not supposed to get cancer. We're not expected to get cancer, or cancer is not something that on the top of my list. So if you look at the colon cancer incidence in the last 10 years, what's changing is, to be honest, actually, the incidence in the older populations actually have decreased by about 2%, whereas the younger population, the incidence is rising. We only are scratching the surface now. I think the data shows that it's about a 1 to 2% increase. But in a practical world, what I'm seeing anecdotally is a lot more increase than what the statistics are showing as we speak. It's probably that the statistics are lagging behind. In 2023, between colon and rectal cancer, we are going to be seeing more than 150,000 new cases. We understand the lifetime risk is about 1 in 23 in men, 26 in women. And mortality, if you look at the mortality, about more than 50,000 people die every single year from colon cancer, which is still, we have a lot more room to improve those outcomes. The age-specific incidence. The reason why I put this picture is, if you look at the ages between 40 to 55, you see how quickly it jumps from about 10 to 15% to suddenly now to 60% in a very short span of time. And if we go beyond 65, 70, to some extent, it's understandable, partly because of the aging process that leads to generally a higher incidence of any cancer. But this age group particularly concerns us when we look at this graph, is like, what can we do to prevent or screen or to detect cancers early in that age population? I think while we talk about colon cancer, we also have to talk about what actually leads to this. We talked about a nice functioning of a brake and accelerator and mechanics. If we have all three of them well aligned, what should we worry about this colon cancer? There's a part of it, about 10% of the colon cancers can be inherited, but most of the rest of the mutations in colorectal cancer are actually not inherited. But saying that, these are the mutations that can happen in one's life as we live on. Some of the inherited mutations are, one of the ones called FAP. It's called familial, I'll give few little pointers on each one of them. Familial adenomatous polyposis. It's actually a problem in a gene called APC gene, adenomatous polyposis colon gene. It's an autosomal dominant. That means one family member is sufficient in the family history to pass on the gene to the next generations. But it can be expressed in many different ways. That means one could have a gene, but may not get cancer. But these particular FAP presents with many different polyps in the colon. Usually hundreds of them. Most of these people with the FAP syndrome need colonoscopies a lot earlier. They usually develop colon cancer by their 20s or sometimes by 30s. And they do require sometimes the whole colon to be removed to prevent, because their chances of developing colon cancer in their life is about 100%. Whereas the next one called hereditary non-polyposis colon cancer, which is also called the Lynch syndrome, it's the most common of all the genetic syndromes in the colon cancer. But this particular syndrome not only causes colon cancer, but also can cause brain cancers, stomach cancers, small bowel cancers, pancreatic cancers, etc. This is a problem with the DNA repair gene. We talked about the repair. That means our mechanic is a problem. So when there is a mutation, your body cannot repair it, and thereby those cells continue on to grow into a cancer. The third one is called the Peutz-Jeghers syndrome. It's not a very common one. It typically presents predominantly in Caucasian population. They have lots of freckles. They present with something called hamartomas, which is basically these blood vessel problems in the colon that eventually lead on to the cancers. MUTYH associated polyp is called a MAP syndrome. This is where we call it a problem with proofreading. That means we have a mechanic fixed the problem, but can someone check and make sure that that problem was fixed by the mechanic properly? That's where there is a problem in this MAP syndrome. It cannot proofread the DNA very well, and that's where, again, it's not a very common one, about 1% of the colon cancers. The last and not the least, but the most common of the mutations are acquired gene. These are the risk factors that we acquire over our lifetime that lead to mutations, and those mutations eventually lead on to, or these are the mutations that we just don't have much insight into yet, that leads to colon cancers. Some of the risk factors, I always like to divide them into what are the things that we can change, what are the things that we cannot change? Like, for example, non-modifiable risk factors. Age, something that we cannot change. Our gender, our ethnicity, our family history. If we have a history of inflammatory bowel disease like ulcerative colitis or Crohn's disease, certain genetic syndromes, these are the things we can't do much about it. We have them, we're going to have to deal with them. But there are certain risk factors that we can certainly work on and modify them, like smoking, or alcohol consumption, or high consumption of processed foods, red meat, low intake of fruits and vegetables, obesity, lack of physical activity. These are the things that we can control, and that's why they're called the modifiable factors. How can we reduce some of them? Simple things, these are called what we call the lifestyle factor, or lifestyle reduction in the risk, like eating healthy, lots of fruits, vegetables, whole grains that contains especially the antioxidants, which have shown in general to improve your immunity and reduce the risk of cancer. Exercise, regular systematic exercise. If someone is smoking, quitting smoking, drinking in moderation, and also focusing on balanced weight. It can be done in many different ways to achieve our goal. And these are the factors that alleviate, in general, the risk, especially the colon cancer risk. And there are other ways. Knowing your genetic history. I think Ravina mentioned part of it, that we don't. There was no family history. So interestingly, I always talk to my patients about ask our families. As culturally speaking, most people who come from Asia and Africa, we don't tend to talk about our family history. We don't talk about what happened to grandpa, what happened to grandma, what happened to father, uncle, maternal aunt, etc. Because it's just a way to say you don't need to know about it. I think it's important to everyone to know what's their family. Was there any family members who died early? Why did they die early? So, and also at the same time, our prior generations did life expectancy was in 60s, meaning that some of them could have died for other reasons prior to developing cancers. But knowing a comprehensive family history, I think, is a key factor in identifying what is my risk, or where do I stand in terms of the risk. So, of course, there are guidelines for the rest of the genetic syndromes and genetic counseling. Now we have access to genetic counseling quite a bit, so we don't have to worry about finding one to know your risk to start with. Some of the warning signs, as again, I'm taking Ravina's words there, how she was having a lot of abdominal symptoms, but these symptoms can be very different depending on where the cancer is starting. So it's like a little I call M. If you're starting from the left side of the M, your symptoms are very mild and it can take a long time. If you do have bleeding, the bleeding is so minimal that we fail to notice. And the second thing, I know many times my patients correct me whenever I ask them, do you see any blood in the stool? They say like, doc, how many times we look at your stool? We don't. That's still human nature of us. So it's a question, but sometimes it's the smell. Sometimes it's the little thing that you catch when you're flushing, etc. So it's when the cancer start on the right side of the colon, the symptoms can take longer, meaning that they tend to present with the later stages of cancer. When the cancer start on the left side of the colon, where that little red thing is there, symptoms tend to start sooner, so you tend to present with symptoms. But there's no reason. My general pet peeve for everybody is, if someone is having a symptom and that symptom makes you wonder, what's going on? And if this symptom is going on for a month, it's time to ask someone, I'm feeling this way, why do you think that is? Generally your primary care doctor or someone or someone who has a medical background. It's important. Anytime a symptom is going on beyond a month, it's an indication in your mind, say, why? So that's something. We all tend to lean on towards work, stress, life. It's okay, it's not me, it may not be me, I don't do anything, I don't smoke, I don't drink. So, but a time duration of over a month is a red flag to say, I need to find out what's going on. Screening. So I usually divide this into three different range of people. For people with average risk means these are the people who may have a family history or may not have history, but they have other risk factors, whether it's weight or some alcohol use or processed meats or food. Most of those fall in that average risk. Now the recommendation starting age is about 45 to screen. But how we screen, we'll talk about it. But when we reach to 76 to 85, we use certain factors like what's their overall health, what's their general life expectancy before we decide should we continue the screening. If someone is over 85, there's no recommendations to screen, but I always feel like we should go back to the clinical factors to decide if someone needs screening or not. There are some who have increased risk. Increased risk means one or more family members with a history of colon cancer. Certain types of polyps, like the polyps can be like a little pocket or a flat. A flat polyps tend to have a higher risk of colon cancer than like a pocket. So those are the patients where they're considered a higher risk, or people who had a history of colon cancer in the past, they're considered an increased risk. Someone who had pelvic radiation. See, those are people you tend to start before 45. Again, it depends on many factors to decide which is the appropriate age. We may need to screen them more often, like every 3 years or every 5 years. And there are certain specific tests that we use for this population, like we don't use Cologuard as a way to screen, but we instead focus a lot more on colonoscopy. High risk. These are the genetic syndromes, patients with inflammatory colitis, Crohn's disease. Starting age depends on many factors. They get a lot more screening, a lot more often, and specific tests like colonoscopies. These are general pros and cons of each test. The first slide is going to be about the simple ones. We call it guaiac-based fecal occult blood test. Basically, you're looking for in the stool for any signs of blood. It's typically done once a year. The advantages are it's a very simple test. The disadvantages are it's not a really great test. The screening, the sensitivity of this test is very low. It's about 30 to 40% range. And it does not detect some polyps, especially the flat ones, because they don't bleed very much sometimes. There are lots of false positives possible. And if someone has hemorrhoids, sometimes it can be positive as well. So, but a positive result, then definitely they need colonoscopy. The second one is an immunohistochemical test. Don't use a whole lot about it. I'm not going to dwell into it. Let's focus on the multi-targeted stool DNA test, which is like the Cologuard test. Typically, between 1 to 3 years, recommendations are done every 3 years. There's no prep needed, very simple, private, etc. But again, it does not detect some polyps. False positives are possible, but if it's positive, then we need colonoscopy. Cost is a little bit higher, but now a lot of insurances do cover that test. These are the tests which are a little bit more invasive, like colonoscopy. But the advantage is it's one of the most sensitive tests. It's actually the most foolproof test and you want to go to a gastroenterologist, not necessarily anyone else who is doing colonoscopies, because the more they see, the more their eye can catch those polyps very easily. So it's one of the most reliable ones, and you can go all the way to the extent of the colon. And the disadvantages are it can still miss some polyps, but it's still the best out of all the tests. But of course, it requires a little bit of sedation. And what most people say is the prep work really is awful. I mean, a lot of people just throw up, have diarrhea all day. The prep is the worst, but it's done only every 10 years. Yes, you have to go through some inconvenience for every 10 years. CT colonography starting to gain some attention. It's done every 5 years. And of course, you're exposing yourself to radiation. It's not something that we use very often. Sigmoidoscopy is very easy to do every 5 years, but again, it doesn't cover that entire M. It covers part of it, which is not enough because we miss the other side of the cancers. Flexible sigmoidoscopy with a combination test, not something we would recommend, but it's something that's been tested as well. Staging and survival. So there's lots of tests one could go through once they're diagnosed. History and exam. There are blood tests. We use something called tumor markers. These are not very specific to cancers. That means we don't use tumor markers to diagnose cancer, but it is great test to follow someone who was diagnosed with cancer. A colonoscopy, a biopsy is something that we take a little sample, look under the microscope to see how the cancer cells look like. CT scans are generally the common modality of test. Sometimes we do MRI, especially for the rectal cancer, or if you want to look at the liver a lot more specifically. PET scans are a very commonly used test to look at the entire body to see if it has spread in. The new kid in the block is what we call next generation sequencing. What it basically means is getting an insight into the molecular aspect of these cancer cells, so we can identify, are there any specific signals that is driving this cancer, which we can target as opposed to giving a generalized chemotherapies. This is generally the staging. The blue ones represents the four walls of the colon, and at which each depth in the wall, it's like, imagine like our wall in the house. If you put a hole in it, you're trying to check, did it go through or did it go through which layers of the colon? That's the T. The green ones at the bottom are the lymph nodes. The more the number of lymph nodes the cancer has spread to, the more chances that it's hiding somewhere else. And metastasis means it could have gone to omentum, which is a layer. Imagine like a little blanket on your bed that is so flimsy that you can't normally see. Liver is an organ that it commonly tends to spread. Percent of cases by the stage. Almost 1/3 of the cases present in a localized way, like confined to the primary place. Regional means it's spread to the lymph nodes in about 36%. Distant is about 22%. I think if you look at the total percentage, almost 60% of the cases are presenting in some form of an advanced stage, more than 60%. If you look at the 5-year survival, you can see with the localized, the 5-year survival is about greater than 90%. It suddenly drops to 15% with distant metastasis. I think we have a lot more room to improve that. If we can improve the localized cancer detection by stage from 37% to say 60%, we can increase the distant metastasis survival by another 15-20%. So there is a lot more room to work on there. I'm going to briefly mention about the treatment. So there are local treatments, regional treatments, and systemic treatments. That means like these are the initiatives we take, say we're in Charlotte. There are some initiatives we take across the state, and there are some initiatives we take across the country. So local treatments are usually the surgery, radiation, or sometimes they can go in and remove that or burn it, or we call it ablation. Systemic treatments are more like chemotherapies, target therapies, and immunotherapies. If I have to give a quick analogy, chemotherapy is like a bomb, meaning it destroys a large number of enemy cells or the cancer cells, but also it can cause a lot of collateral damage, whether it's hair loss or neuropathy or lots of different side effects. Target therapy are more like laser-guided missiles, meaning if you know the pocket, for example, I'm going to throw a few terms there, BRAF, B-R-A-F, something called NTRK, something called MSI, something called KRAS. So these are the different signals we know that is the problem in those cancer cells that actually tells the cancer cell multiply. So target therapy can target those signals, thereby they're more effective than chemotherapies. Immunotherapies are to activate your own immune system to fight the cancer. Simplistically speaking, we have T cells in our body which gets activated, they stay up, and the same mechanism in the T cell tells the T cell, after you're done with your work, just calm down, relax, now you don't need to do anything. What the immunotherapist does is they keep the T cells active, thereby it continues to be very effective on the cancer cells. But the key things to remember, these are the more practical. Making the treatment decisions, understanding what your goals are. What are we trying to achieve here? The two primary things are we trying to cure this cancer, or are we trying to buy time? and what are the side effects of each treatment that's chosen. And the information is the power. And last but not the least, being an oncologist, I'm always recommending my patients, it's okay to get a second opinion. We're not very egoistic to say, I'm the best, you should do whatever I tell you to do. My feeling is everybody deserves a second opinion. When we take opinions about your financial investments, a car repair, or anything that you do in your life, you take 5 different opinions. You take a loan, you take 5 different quotes. Why are we not doing that with the oncology part? At least one other opinion. 5 opinions are not necessary. So I believe that everybody deserves one. Multidisciplinary care, you will have a lot of people involved: surgeons, radiation doctors, medical oncologists, nutrition, palliative care doctors, complementary therapists like acupuncture, music therapy. Lots of different people could be involved in your care. Clinical trials, although we might say trial means an experimental, I don't want to be a guinea pig, but trials are a great way to be exposed to the new advanced state-of-the-art treatments than what. So anytime there's a trial open, it's always good to be a part of the trial. Considering complementary and alternative methods, like what Ravina was talking about, the meditation, all these complement the treatments that you're taking otherwise. It's okay to take help as well through your treatments to support you during the process. Sometimes there might come a time point where you may have to decide between, do I really want to take treatment? Does it add value and meaning to my life? Or is it okay to stop, focus on my quality of life and my time with my precious ones? And it's okay to talk about it. And more importantly, ask questions. If you don't ask questions, you may not get an answer about that. There's no question like a dumb question. There's no question that bothers the people who are helping you through that journey. One last thing I want to talk about before we close. We always talk about diagnosis, treatment, everything. If there are 3 parts to it: screening and prevention, treatment, and after treatment, what happens? Most of the times they're forgotten. I usually put them in 2 ways. Cancer survivor, how do you live as one? I know a lot of people talk to us about living in fear. And how do you alleviate some of the fear? And how do you manage that fear? How do you survive through that fear? And what can you do to educate other people about who has been through that? Second is cancer concerns as survival. I'm sure people who have been through a journey, even if they get a headache now, they're thinking of a cancer coming back. So this is a very, very newer, challenging aspect of how to go about. This is something we're still only scratching the surface as we speak in 2022. As a summary, I want to highlight, I always talk about things in 3. And I think my kids know, everybody knows, I always talk about things in 3. First one is know and alleviate your risk. Unless we recognize our risk, we cannot alleviate that risk. Unless we recognize that, hey, my diet is very off. I need to make some changes with my diet. Unless we recognize, we cannot do anything about it. Screening and prevention. Unless we proactively screen and proactively talk about, proactively stay with your appointments and keeping those things in place is a key. Third, educate and support. If you know something, educate. There are 10 other people who will benefit from what you talk about. It's okay to talk about whatever we go through because it will benefit from someone. I'll close this with one example. I met someone actually just 2 days ago, a lady who is 52 years old, presented to me with a shocking stage 3 colon cancer. But looking back, she only heard about her mother having colon cancer, but she was never tested. And she decided to screen at 45. Everything was good. At 50, she missed because of the pandemic. At 52, after the pandemic is over, she went for a colonoscopy, but she diligently went for a colonoscopy because of the fact that she missed during the pandemic years. They saw only a small, they saw a polyp. The biopsy, it was normal. And she didn't leave it. She went back a year later again, said like, can you remove the polyp? Because they didn't remove it the first time. When they removed it, they saw a very, very tiny amount of cancer cells in there. It was what we call a T1. she was told, you probably have a stage 1 cancer, but I think it might be best to still remove the right part of the colon. When they removed it, she had 10 out of 15 lymph nodes that were positive with cancer. And when we dwelled into the family history, now I learned that her maternal aunt had uterine cancer. Her grandmother actually died of brain cancer. Now we are testing her for Lynch syndrome. I still don't have the results, but my gut feeling is it's going to be positive. The reason, what I'm trying to highlight here is proactive, diligent nature of us is really, in a way, what's going to save our lives. I think I'll close with that. Thank you very much for your attention and your time. I appreciate it. I know I went over a little bit.
No, that's totally fine. Thank you so much, Dr. Raghava. That was so wonderful. You covered everything, from the beginning till the end, and also the survivorship, and also the final statement about the Lynch syndrome and the genetic analysis and the family history, right? So that is so true. So thank you so much. We have many questions for you. So probably we'll take the questions at the end, because we have two esteemed speakers coming up. And once we finish all our presentations, we will open the forum. And so Dr. Neetu and Mr. Mahindra, so we look forward to answering your questions once we finish our speaker session. But thank you so much, Dr. Raghava. You can see in the comment section, so everyone loved your presentation, because that's what we wanted. All the symptoms plus the screening protocol, the lifestyle, the treatment protocol, and you covered everything. Thank you so much. We really appreciate it. Thank you. And now I would like to invite our next speaker, Mr. Jason Reiss. Little bit introduction about Mr. Jason. He is, let me just go to yes. Mr. Jason is 49 years old. He lives in Philadelphia suburb, and he's married to his wonderful wife, Rebecca. Jason is stage 4 colorectal cancer patient. And before more introduction, I just want to be very thankful to Sharon Raviri, who introduced me to Mr. Jason recently, and that's how I'm connected to him. Jason enjoys progressive rock music, Philadelphia sports, and what really touched me is that about how they actually foster cats and kittens who have no one to take care of them, and that's the side of you that kind of reflects you as a person, like how kind-hearted you are. And of course, Jason has 5 cats who he calls as the felon army. Now, he's also, Jason also loves motorsports. He is in the motorsports industry, and he wears several hats, from being event photographer to social media management specialist. He enjoys the muscle car hobby and also spends plenty of time attending local car events when he's not attending the faraway events for work. And Jason loves people, and he cannot stop talking to someone, or starting a conversation, and that can be in a convenience store or a Home Depot. So we can't wait to hear you, Mr. Jason, and thank you so much for your time. And please, the platform is yours, and I formally invite you now. Over to
Wonderful.
you, Mr. Jason.
Thank you so much for the wonderful welcome. Unfortunately, unlike Dr. Raghava, I do not have a massive presentation. You're just going to have to listen to me talk. I thank you very much for having me. This is the first time I'm addressing such a large group of people that I don't know. I will try to keep my story shortish and relevant. As you said, I'm 49 years old. I was diagnosed 481 days ago with stage 4 rectal cancer metastasized to my liver. When I was initially diagnosed, the oncologist that I had at that time told me I was going to be on chemo for life. He didn't know how much he could help me. And if I had waited 6 months longer, he wouldn't have been able to do anything for me at all. So when I initially presented to him, I was experiencing some blood in my stool. I was experiencing fatigue. I had lost some weight, pretty much a textbook case of what the doctor was just talking about. And it does not run in my family. No one else that I am aware of. And I have asked all of my, my parents and everybody else if anybody has had colon cancer, and it does not run in my family. As the doctor was presenting all of the risk factors, those are all of the factors that are probably the reason that I am here. I did smoke when I was younger, and where I live Red meat consumption is relatively high. It's just the way it is. And I'm discovering that you probably have to pay more attention to those sorts of things as people are growing up. And it's incredibly important to me to share the story, not only my story of being sick, but also to help others understand what to look for, right? If we don't talk about it, those of us who have experience with this, if we don't talk about this, other people won't know. I talk about cancer to somebody every day. Sometimes it's many somebody's every day. I have friends who message me to find out how I'm doing. I have random people who see my Facebook posts and message me to talk about symptoms that they are experiencing. It is so important to be checked. And interestingly enough, I wasn't 50. They changed it last year. I was diagnosed at the end of 2021 on November 16th. And then they changed it to 45 years old last year. Obviously, I was already past that. My oncologist told me that he believes my primary tumor was growing for approximately 10 years before I went to him. I had symptoms probably the last 3 of those years that I overlooked. It's a hemorrhoid, right? There's a little spot of blood on the toilet paper. It's a hemorrhoid. I don't see it again for 3 months. It's not a big deal. Oh, I'm losing weight because I'm working so hard, right? All of these things are not tying together in my mind as, hey, dummy, go to the doctor. And finally, I was so fatigued and so worn out, I had no choice. I went to the doctor. Initially, he believed that it was possible my cholesterol medication was causing my elevated liver values. We repeated the blood work in 2 weeks. I think 2 or 3 weeks after that, I had a CT scan. I had no idea what he was looking for. He didn't tell me any of that. All he said was, we need to do this. Okay. I went and I did that. And then all of a sudden it turned into, instead of me begging people, begging my doctors to help me, it turned into my doctors calling me to schedule my appointments because they knew I was sick. So the CT scan turned into a colonoscopy where they confirmed that my primary tumor is in my rectum. At diagnosis, my liver was so covered in tumors, they didn't think there was anything that was going to work, right? That was 480 some days ago. One of the things, let me stop before I go any further. The reason I am actually here talking to you, the reason I am working with Sharon at Saving Pennies for a Cure is because I was friends with her brother, Clarence, who passed away from colon cancer. Clarence and I were sick at the same time. Clarence went into the hospital. We worked together in October of 2021. After that event, Clarence went into the hospital and he was dead 36 or 37 days later. And I'm still here, right? He had stage 4 colon cancer, just like I do. So I'm here because Clarence can't be here. I want to talk to you. I want to share my story with all of the people that are listening. And I thank every one of you for taking time out of your day today to listen to me. I'm here for myself and for Clarence because he can't be here. He didn't have that option to get better. I'm very fortunate that my treatment, the first round of my treatment was called Folfox, which is a couple of drugs, not very pleasant to go through, but my body tolerated it very well for whatever reason. Because my body tolerated it so well, it opened me up to have an opportunity to have another type of treatment through a device called a hepatic artery infusion pump. And what that is about the size of a hockey puck. It's about 3 inches across and about that thick that they implant into your body that delivers chemo directly to your liver for someone like me whose liver was covered in tumors. By the time I got to when they installed this is where it really gets wild. My first HAI pump, I've had 2. Now I have 0 since October. They put the first one in October of last year. It did not heal properly, the incision where they inserted it, but I was able to get one treatment out of it before they had to remove it for fear of infection. On the day they removed it, they installed a second one on the other side of my abdomen, right? I'll stand up very quickly. I won't show you, but the first one was here. The second one was here. Now there aren't any. So when they removed the first one, they installed a second one. I was able to get 3 more treatments of that drug, which is called FUDR. And that drug treats the liver directly, and then the liver processes everything out, and it doesn't affect the rest of your body like my systemic chemo treatment does that I'm also on at the same time. That said, it's 480 some days later, and I'm still here, and I'm not dying anytime soon. But the overarching message is, if you have any symptoms whatsoever, any family history whatsoever, go to the doctor. Tell all your friends to go to the doctor. When I look around the room, when I go out with my friends, everybody looks like me. They all have some gray, mid-40s, late 40s, early 50s. Every time I go somewhere, I talk to someone about cancer, because undoubtedly they ask how I'm doing. It doesn't matter how I'm doing. What are you doing? And that's how I approach it with every single one of them. When they, how are you? No, it's not about me. What's happening to me is whatever drugs we use are hopefully doing what they're supposed to do. I'm not dead yet. I'm standing here talking to you. What are you doing to not be me? I ask every friend I have that question. I keep track of the people who have gotten checked because of me. And I'm up to 139 people that have reported back to me that they've had colonoscopies done because of my situation and me talking about it. And 36 of those people have had polyps removed, right? Every one of those 36 people is married. Most of them have children. Several of them have grandchildren. How many of lives have I affected positively by that person getting checked and having their polyps removed just by talking about my situation? So it's critical that any of us, and I know the gentleman coming after me is also a patient, something I want to talk about. I'm not sure if everyone here is male or female. It's hard to tell because I don't recognize your names, and I apologize. If you are a male and if you are a patient or a caregiver for a male or female cancer patient, I work with a group called Man Up to Cancer that is on Facebook. Man Up to Cancer is a men's only group for men with cancer, men who are caregivers of someone with cancer, to provide the type of support that's traditionally hard for men, right? Especially white men. I'm not sure how it is in the Black and brown community, but it's a place where a guy can go, whether it's me or Dr. Raghava or somebody else that might be here, and ask a question that may be sensitive, right? A sexual side effect, because you get those when you have colorectal cancer, when they have to do radiation on your reproductive parts, it can affect that. Men typically isolate. They don't seek out help. They don't talk about it. They get sick and they feel crappy and then they die. I'm not dying. I want to help other people not die. So Man Up to Cancer was started by a friend of mine. I got involved in it very quickly after I was diagnosed. I'm actually going to Washington, D.C. tomorrow afternoon for the Colorectal Cancer Colon Congress. And I will be there tomorrow and Monday. It's so critical to talk to the people that you care about, and even the people you don't care about, really, about colorectal cancer. I have it. I have a couple of friends there was a friend of mine who was diagnosed before me. I knew a little bit of what to do because he had talked about it a little bit. But since I got sick, now he talks about it a lot because I have kind of pulled him into helping me with that. Like I started to say earlier, none of what I go through currently is about me. It is 100% about the people who are behind me that haven't been diagnosed yet, or don't know that they're sick, or don't know what to do, or how do I talk to someone about this? It's easy for me to talk. I love people, like you said in my intro. I love to talk to people. I love to hear their story. Life is nothing without experiences, right? And you have to share your experiences, good or bad, with the people that you care about. So I do that on a regular basis. I'm very fortunate to have a wonderful wife. I don't know what I would do. I probably wouldn't be here if it wasn't for her kind of saving me from myself. But at the end of the day, you have to get checked. You have to spread the word. That's really what it comes down to. I'm very fortunate to be here 480 some days later, and I count those days. When I had my hepatic artery pumps installed and then removed, that was very traumatic, because I was under the understanding that that was my best path to potential cure, remission, whatever you'd like to call it. But because I was able to get those 4 treatments through the pumps before they had to be removed, I believe that the next time I'm scanned, which is April 24th, I'm hopeful that my doctor says, I don't have any cancer to cut out of you. I don't know if that's going to happen. My original diagnosis, when we would look at the scans of my liver, they show you the material, like as they scan, it goes down your body, right? Like from your neck to your waist. And the doctor, when he shows you on the screen, he can roll down each of those, what they call slices, or what he calls slices of different images. When I see the images of my liver, actually, if I try, I might be able to share that. Let me see if I can find a picture on my Facebook page, because that will be very helpful for people to see what that looks like. Give me 1 second here and I will find that picture. So ultimately, the fact that I'm here today and I'm able to talk about all of this stuff is a big deal to me. I'm very fortunate, right? Most people who are in my, here we go. Here's the picture. Let me see how to share my screen. Sorry if there's some extraneous stuff on the picture it says host disabled participant screen sharing. So you have to give me some access here. Lopa. I can't share it if you don't let me.
I thought I did. Sorry about that. So just give me, if you can just, I'll do the gallery and I'll just make you the co-host. Yeah. Yep, you can.
There we go. Okay, so let me call it back up on the screen here and then figure out how to share it from there. Share screen. Oh, okay, I think it will be this. Hopefully there's nothing there that you got. No, hold on.
We don't see it
there
yet.
We go. No, there we go. I have to give it permission, my computer, because I don't normally.
Oh, okay.
There we go. Zoom may not be, I don't want to record. All right. Can you see it now, or is that not showing?
No, it's not showing yet.
That's very strange. Okay, so what I'll do then, I'll make it even easier, because it's easy enough for me to take a screenshot and just share it into the chat. Let's do it that way. That's probably way easier than me fooling around or trying to figure out what I was just doing. Okay, so this is going to sound crazy. Can someone with a long name message me so that I can change it from the direct message? I can't change the drop down because I can't see the left side of it. Lopa, if you could message me, I can do what I'm trying to do.
Yeah, I just messaged you, Jason. So did you see like a message to everyone? Or you want a direct message or to everyone?
The direct message, please.
Okay, I'll do that now. Yeah.
Yeah, because what's happened is somehow my chat box window.
Yeah. Do you see my direct message?
I do, but I still can't change it. This is crazy.
That's fine. So probably,
anyway,
if you want to share it with me, because I'm going to send everyone the recorded session, so I can send the image as a copy, as an attachment for sure.
Yes, I can
So
message
you
you
can
right now.
email
and
me
actually
afterwards. Yes, absolutely.
send it this way. Here we go. All right. I'll send it to you in just a moment. Okay.
Sounds
So
good. All right.
ultimately, there was so much disease on my liver that I didn't know if I was going to live or die. Right. At first, I didn't know if I was going to see the end of the year because Clarence had died already. Right. Clarence, we were feeling the same way. It wasn't like he was better or worse than me. His had metastasized into his bones. Mine is not there. It is currently still only in my liver. My primary tumor is still in place. I have not had any surgery yet. I've had Folfox chemo. I'm now on Vectibix and irinotecan, which is my current plan. And I was also on the FUDR that was in the liver pump. Unfortunately, as I was talking about earlier, they put in the second liver pump, removed the first liver pump. The second incision did not heal properly either. So that was removed on Valentine's Day. So now I don't have that option available to me. But my belief on because of how I feel, my belief is that my treatment has worked so well, most of it is gone. When my surgeon, and I'm not sure if you're familiar with Dr. DiMatteo here at Penn, but Dr. DiMatteo is the head of liver surgery here at Penn. He does a lot of cancer research and such as well. And when I asked him after my last set of scans, he said, I don't have enough material to work with to cut up to do a liver resection, which is the goal, to try to remove all of the cancerous material. From his belief, he believes everything is calcified and there's not really anything he could do with that. He doesn't want to cut me open just to take a look. So we'll see what happens with my next set of scans. But ultimately, the overarching message is please get checked, get your family members checked. If you have anything whatsoever, please go to the doctor. And if you have questions, doesn't matter whether we are on this call or not, feel free to send me a Facebook request, send me messages. I will be happy to talk to you. I have no dignity left. So if you want to talk about something that you think might be sensitive for somebody else, I've already talked about it with my doctors and probably my friends. I'm not afraid to talk about poop or sex side effects or whatever you're going through. If there is a way that I can help you, please do not hesitate to contact me. I'm here. That's what I'm here for. That's the end of my story. I could talk for hours, but I don't want to waste people's time. I appreciate everyone listening to me. I'm very honored. I feel very fortunate to be here to talk to all of you people. So thank you for your time today.
Thank you. Thank you, Jason. Actually, we feel so honored to listen to you. And you must be seeing the chat room like overpouring with wishes and love. And, we all think like you are our family now. So thank you so much, Jason. And such an inspiring story. And yes, everything will be fine. Your April scans, and I'll definitely be following up because that's me.
Yes.
So, but
I'm not going anywhere anytime soon. I'm
you
going to be here
cannot.
for years to come.
Yes,
So
absolutely. You have to be here for all our webinars coming forward.
Yes.
And yes, so saying that, thank you again, Jason. And I'll share your email address with everyone so that if anyone wants to reach out to you, so that I can connect them with you and they can share, you can discuss and take it forward for sure. So saying that, I would like to invite our next speaker, Mr. Krishnan Iyer. And of course, the word "C" connected us, and he's wonderful. I've met him, his family, so again, built into a relationship. So he is a CRC advocate. He works at North Carolina State University. And most importantly, I think once you hear him, you will know such a humble, kind gentleman he is. Over to you, Mr. Krishnan.
Thank you, Lopa. What a wonderful group of speakers you had before me. It was really very, very informative and inspiring. I will primarily focus on what my experience was or is, and how my journey was, and on the way what I learned and how my perspective changed and things like that. Let me try to see if I can share my screen.
Yes, we can see your screen, Krishnan.
Okay, very
Yes.
good. All right. So let's start with a short introduction. My name is Krishnan Iyer. I'm living in Raleigh, North Carolina. I work at NC State University, and we're living here. My family, my lovely wife, Priya, and we have 2 children. My older one, my son, Kirtik, is in college, and our daughter, Kavya, is in high school. And we have a wonderful dog, Luna. And we, as a family, we love traveling and like outdoors. We like camping during summer season. And both my wife and I love running. We do regular long distance running, but my running has changed to walking for obvious reasons, but we still go out and do as much as we can. So what I'm going to talk about is primarily about the screening, the importance of screening and follow-ups. Everybody talked about that, and by now you know how important it is, but I'll stress on that fact one more time. And then I will talk about the treatment plan that I was presented with and what the process was. And I'd also like to go a little bit into the details of the actual treatment and how I faced that, and what were the learnings and what was easy, what was hard, kind of thing. I would like to share how my perspectives changed. Boy, do they change. You have a certain view before you are familiar with the disease and the treatment and the things. And once you're faced with that and get into the details, and when you really go through that, your perspectives change a lot. And I'd like to touch on that. And then I'll conclude by looking ahead. What's next? How the future is going to look like. I'm sure all of you guys are here because of some kind of connection to cancer, one way or the other. Either you've seen that directly, or you have some loved ones or friends or somebody, or some format or the other. So there isn't a real need to stress on that importance of screening, but here we are. It is still important that you share that with the people around you, people that you meet, and spread the word, the need for catching it early. In my case, I didn't have any symptom at all, I should say. We have this annual checkup, and my primary care physician said when I turned 50, it said that, oh, maybe you should get your colonoscopy done. And there wasn't any urgency, there wasn't any push for that. He also offered, oh, by the way, there are some stool tests you can do. Maybe we can take that and see if you want to go, if you don't want to get that invasive colonoscopy. And clearly, that is it's an invasive process. There's some prep work, like Dr. Raghava was explaining. And given the option of an easier route, I took that, stool test, and that is non-invasive, but clearly not the most reliable one, because you're sending only a small portion of your stool, and it's like a random piece that they test. And those things came back negative, and everything was looking good. The next year, he said that, oh, by the way, there's Cologuard, maybe you should do that. He was still not pushing anybody. It was left to me whether to do, colonoscopy or not. And sure, Cologuard is again non-invasive, but the difference is Cologuard, as some of you may already know, it's not a little bit random piece of the stool. It's a whole stool that you put in a package and send it, and they analyze the whole stool. So it's a little bit more reliable. And in my case, it came back as positive. So I would say it is very reliable. But there are some, I don't have any other data, but I've read the data, and it's supposedly highly reliable. And sure enough, there will be false negatives and false positives. So take it for what it is worth. But if it comes as positive, then clearly the next step is colonoscopy. So I went for a colonoscopy. This was back in 2021, July, August timeframe, June, July timeframe. And my colonoscopy clearly came back as positive, and they found a mass in my rectal area, lower colon rectal area. Colonoscopy is a little bit invasive. You have to do that 1 day preparation, fluid diet, and the anesthesia, put it down, and you got to wake up from that. And there's a little bit of inconvenience, in my opinion. But hey, a little bit of inconvenience and coming back with a negative result is way better than not going through that inconvenience and then dealing with all kinds of things. So that is the one that I highly recommend. Depending on your age group, if your doctor suggests, they may not even force you. If your primary care suggests, hey, it's time, take it and go do it. Do not wait for any symptoms. And like the rest of the speakers said, if you have any symptoms, no matter whether you're in that age group or not, if you have any symptoms, address it, talk to people and see if you want to do, if they recommend any follow-up tests. So it's very, very important. I cannot stress enough on that colonoscopy, the need for that. Don't really go through the other smaller, easier routes. If you're in that age group, don't take that easier route. I would say just do the colonoscopy. So in my case, came back as positive, as I said, and then the next step was, go seek a provider, talk to cancer specialists, and see what the next steps are. Selecting a provider is a challenge, and we got to we get lots of information from different quarters. Once you're identified as a cancer patient, then everybody wants to help you. You'll be flooded with information. This place is good. This doctor is good. This hospital is good. There's a lot of input comes your way, and like Dr. Raghava said, second opinion is also equally important. I didn't do that part. I more or less decided on a location and went with that. In my experience, from what I have read, the treatment regimen is more or less the same globally. So just because you change your hospital, pick a different hospital, doesn't mean that your treatment is going to be completely different. I think that's pretty standardized. So there may be other factors that play a bigger role in selecting that provider, the location. For example, proximity, transportation, all those logistics will probably play a bigger role. General reputation and what the history of certain hospitals or doctors are. Sometimes insurance coverage may play a role as well. So those factors have a bigger influence in your decision than the actual treatment regimen. That's going to be pretty much the same. In my case, the treatment plan as they laid out was 3 parts. They wanted to do radiation first in my pelvic rectal area, and the hope was that that'll shrink the tumor to a manageable size. And then there's chemotherapy planned for that, again, with the same intention that it'll take care of the growth or the rate of growth, and also address if there is any potential spread in other places. And then finally, a surgery to remove the actual tumor. In my case, it was in the rectal area, so that the surgery would be removal of portion of colon and rectum. It is a long process. It will extend for months, and potential delays in between. For example, if you have some side effects so that you're not able to take the next stage, primarily during the chemotherapy session, they monitor your blood level, blood counts, and general health, whether you're ready to take the next dose or not. Mine was once in 2 weeks. I think that's pretty standard. Once in 2 weeks, you get an IV. But then before they do that, they have to maintain your blood counts are in decent shape. If not, there's a chance that it gets delayed. So the initial projection of 8 sessions, once in 2 weeks, will cut down, do the math, it'll be 4 months. but it can go to like 6 months, 8 months, depending on your general health and other situations. But it is equally important that you are able to cover all those sessions. Sometimes I've heard cases where people who are not able to cover, they got to stop that halfway through, or for some reason or the other. It's better to be able to push through and finish the complete cycle as the recommendation is as much as possible. There will be some inconvenience, difficulties during that time, but in the end, it's going to be good. It's a good solution. So that's how I viewed. I did have some difficulties during that time too. We'll talk about that in a second. During treatment, so I want to touch on those 3 sections and talk about, quickly cover how I felt and what I did to overcome some of the difficulties. Radiation was the first one, was 30 days, every day, every single day, get radiation. But that was pretty straightforward in my experience. It takes about 15 minutes. You know, my location is like 20 minutes drive to the hospital. It takes about 15 minutes of radiation process, change and get the radiation dose and come out. So it was very, very straightforward. I had absolutely no side effects in the initial days, and I was thinking, wow, this is nothing. But it did creep in towards the latter part of second half of that cycle of 30 days. I had some difficulties, primarily around bowel movements and difficulty during bowel movements and some blood in stool again. And because of the whole region is irritated with radiation. And it did continue even after the radiation stopped. Clearly, the tissues are irritated, and it's going to stay like that for some time before it can all heal. So there was a little bit of difficulty there, but again, that's the process you go through, and it is not something unmanageable. It is definitely manageable, but just something that I had to deal with. Again, the next stage was chemotherapy. The recommendation was to do 8 sessions, once in 2 weeks, so spans over 4 or 5 months. Along with that, they had recommended oral chemo with a tablet. There are some side effects for that. Even for the oral chemo, in my case, I had some chest tightness, and that the doctors thought that that is not something that they want to deal with, and they stopped and then discontinued that, and switched over to IV, a second IV, not the regular IV. My IV was once in 2 weeks, and along with that, the replacement of that capecitabine was done through an IV that I carry for a pump that I carry for 2 days or so. So the IV, like I said, was once in 2 weeks. Yes, there were some difficulties during that time. But again, it is not as bad as what you would think without really seeing this or without really experiencing it. The peak of that difficulty was the next 2 days or so. You get mainly into nausea and fatigue, and it fades off over the weekend. My treatment was on Tuesday. By Wednesday, Thursday, I'm pretty much getting back to normal. By over the weekend, everything is back to normal. I'm able to eat, and even during that session, I was able to eat, and it's important that you eat. Getting back on track, and the next week is pretty normal. A little bit tired, pretty normal, and then you're ready for the next session. Like I said, before the session, there's they monitor your blood level and make sure that you're ready to take the next one. In my case, almost everything was on track except for one session where my white blood count was high or off the chart. I don't remember whether it was high or low, one of those two, and they had to delay it by a week. And after that, everything was on time. Every 2 weeks, I was able to get that. And you get it on a Tuesday, 2 or 3 days of difficulties, and of these, one day was pretty pretty fuzzy. I don't even remember that day how it went because my brain is so fuzzy. And then I get back to normal and then repeat the cycle. It's not bad, but during that time, it may appear like it is really, really horrible, but really it's not. It is manageable. And then with a gap of about a month or so for the body to get back to normal after the chemo cycle is done, I start with the plan for the surgery. The initial surgery is to remove the tumor. In my case, it was the rectal area, remove part of colon and part of rectum. And it is a long surgery. I would say the surgery part is not as bad as what I thought it would be. Part of the reason is you don't even know, you're in anesthesia and the surgery is done by the time you wake up. So, and then the recovery is pretty straightforward. There was some pain at the incision area, and but the actual surgery time was pretty long, and recovery period is about 6 weeks. And in my case, there was some infection in the leak, so that's a side story. I had to deal with that, and they had to put a drain, and sometimes it happens, and that may delay the recovery a little bit. I extended that a little bit, and another thing I want to touch on is in many rectal surgeries, or I think in almost all of them, there will be a temporary ileostomy. For those who are not familiar with that, it's a bypass. So you don't want, when the colon is connected back, you don't want the normal stool bowel movement through that before it all heals. So there's a bypass that's put as a temporary bag from your ileum through your abdomen. That was probably the most, the one that caused the biggest anxiety in my mind. I was very, very anxious. I did not know what to expect, and I was dealing with that. I had some difficulty with anxiety during that time, but that's a temporary one. It's a temporary bag, and I got to deal with the process of cleaning and emptying and removing, replacing, and things like that. There are well-established practices. There are nurses that are experienced with that, very compassionate, very helpful. Take the help of them, and that will be a breeze. But before I went in, I did not know any of that, and I was extremely anxious about that. So that affected my mental health a lot during that time, or before that time, and partly during that time. I'll come to that mental health situation in a second, but I wanted to talk about the actual process. The ileostomy is a temporary one. It lasts for about 3 or 4 months, depending on your recovery and healing process and healing rate. There's a reversal surgery where they got to put the ileum, take the bag out and put everything back, and then your normal digestion and the bowel movement will take place. The reversal is after 3 months or so, 4 months in my case, because of the leak that I had and the infection that I had to deal with that. That is a relatively shorter surgery. Once you've seen that longer one, then 2-hour surgery is nothing, right? So that's an easier one to deal with as far as the actual surgery is concerned. The real challenge will be when your regular bowel movement and the process takes place. Now your colon is shorter, so it has less, your body has less room to process, and part of your rectum is lost. So rectum is the storage for stool, your body has to adjust to all that. So there'll be frequent bowel movements and things like that you'll have to deal with. And slowly, I'm told that body knows how to take care of itself, and slowly it'll get back to some level of normalcy. That's the process. But again, looking from outside, these things appear to be pretty daunting and scary, and very sounded like a sad thing to go through. but when you actually deal with that, when you actually see that, it's pretty amazing, quite honestly, as to the capabilities of medical science, that you can take the stool, the bowel movement out as a bypass, and give the body a chance to recover. And it's pretty amazing. And then once your body recovers, you can put everything back, just like a plumbing, right? I'm an engineer by profession, and a lot of things I'm able to relate to regular engineering. Your body is a huge, big machine behind the scenes, right? So it is pretty amazing in a way, if you think about it. But that was one of the biggest challenges in my whole journey, that how to deal with that and how to accept that. Mental health during treatment is extremely, extremely important. A lot of us have a tendency, depending on your background and your lifestyle and where you grew up, how you grew up. Sometimes we have a tendency to ignore the mental struggle. Physical struggle is easy to express, easy to show, easy to detect. There are tests to detect that, and there are drug medications, and you can see the effect of that. Mental struggle is a little bit complicated. There may be a taboo in some societies, in some cases, as to even address that. But I think that it is extremely important that we pay equal attention, if not more, because as we all know, mind and body are connected. And a strong mental health, a healthy mind will definitely help body recover faster. So focus on mental health is extremely important. Don't lose track of that. In my case, I had some anxiety episodes throughout the whole thing, as soon as it was detected, and during the chemotherapy, and before surgery, and the prognosis, and the whole process when it was described to me was all scary. How am I going to deal with the bag? How am I going to deal with what if the bag is going to be permanent? So all those things will pop up in your head and cause a lot of anxiety. Seek out support. It's extremely important to recognize that and intervene. Don't let it, don't brush it aside saying that, oh, that's just psychological. You're just feeling it. It's not real. It is real because you're feeling it. So don't let this is true for patients and caregivers and loved ones. Everyone will go through this, not necessarily the only person that's going to go through this mental situation is the one who's dealing with treatment. The people around them are also going to face this. So it is very, very important to recognize that and take action, intervene, seek out help, support groups. A lot of hospitals have a support system specifically addressing this in their cancer department. At least my hospital had that. They have a connected mental health department associated with the oncology department, because it is so common. And there's also the situational depression. People who didn't have any depression may go through some kind of depression during this time. It is extremely important to not brush it aside, recognize it, talk about it, come in the out, and then go talk to professional, talk to support groups. That I cannot stress that enough. And the last one I want to cover is probably more important, equally important, if not more important than anything else. That's the health of caregivers. They are struggling in their own ways. In my case, it was mostly my wife. They are struggling in their own ways that they may not share with you. Recognize their needs during the time. Both mental and physical health are the caregiver. And same situation, they may be going through some depression or anxiety themselves, and they don't want to tell you because you're struggling. So where do they go? And keep everything inside. So it is important to recognize, it is important to come out and talk and give them the support that they need, take them to the same kind of support group or professionals, and take action, avoid burnout. It is important to have that mental relaxation for them, enjoy, to travel or go out and eat, if you want to eat outside or go on short trips or engage in some hobbies or something, take a walk outside. These things are small steps, but very, very important. Physical health clearly is easier to explain. Take breaks, get enough sleep, and if there are multiple people to help get into a shift system, and not everybody should be together in supporting. Take shifts, be clear about look at the hospital system. They have nurses in shifts. They don't get burnt out. Share the load with others. It is extremely important. And take the help of support from friends and family. In my case, or was a small friend group that came in and helped with food. Simple things. They supply food, so my wife didn't have to worry too much about what to eat, what to cook, and things like that. So take that support groups help. It is very, very important to take care of your caregiver. All right. So with that, going through this, in my case, there is a little bit of complication. My radiation and chemotherapy and surgery and reversal, ileostomy, everything was done, and I was on a track to recovery. And I went through a scan as a follow-up, and they did find a mass in my rectal area, which turned out to be, so I did a colonoscopy again, and they did find that it was cancerous. This was after surgery. Now, there is a little bit of uncertainty. There's a little bit of a gray area there. I don't want to go into the details, whether that spot was missed in the earlier surgery or this was a new growth. We're still trying to understand that. But long story short, I had to go through the same cycle of surgery. There was another surgery that happened in January, where the remaining portion of rectum had to be removed to take care of this mass. And in the pathology report, the report came back with clearly it was cancerous, but the lymph nodes did not show any cancer in there. So I think that's a positive sign. And the doctors do not think I will need chemo radiation at this time after the surgery, because they believe they got everything out, but there will be continued monitoring. And this is the same repeat of the previous surgery. So there was a temporary ileostomy put with a bag, and I am in the recovery stage right now. I got to go through that recovery and let it heal completely, and then there will be a reversal surgery to take the ileostomy out, and then I got to see how that reversal is going to go through in terms of my normal, digestion and bowel movement and things like that. So that's upcoming for me in my particular case. But in general, if it is a surgery that was everything got completely removed, then it's a recovery stage going ahead. So how did my perspective change? What was my perspective before, and how did it change? In the interest of time, I'll go through this real quick. My previous outlook about cancer was pretty much zero, nothing. I had no knowledge of the disease, no knowledge of the treatment process. Of course, we all have heard cancer, and we all have heard chemotherapy, right? Radiation, right? But beyond that, I didn't know anything. But starting with this diagnosis, I had to first understand what is in store for me in terms of treatment. There was fortunately or unfortunately, there was a patient in care itself had the same situation, who went through the same kind of treatment. I met with them, and they explained what they had and how the treatment was, and that gave me some understanding, a better understanding of what to expect. and how to prepare. Each patient is different. So got to keep that in mind every time you talk to somebody. Their experience is their experience. Your experience may be completely different. There may be some similarities. So just because somebody had one situation, one side effect doesn't mean that, oh, I'm going to get that. You know, these things will pop in your head. Oh, they had that, so I'm going to get. No, that's not true. You may get, you may not get. But it did help prepare as to what's coming up. I didn't do a whole lot of Googling or reading of or anything of that sort. I left it to the doctors and trust their experience. They are better equipped than any Google report. So I'm going to leave it like that. Input and support from other support groups, BCH, I should call that out, was very, very helpful. That's around the time that I got introduced to Lopa, and her support was amazing. I talked to Ravina, call it out. Ravina was very, very helpful. And talked to Uma. Uma was extremely helpful. Some of them are already here. And several others who gave, we have a WhatsApp chat group, and all the inputs coming in from there were very, very helpful. With that, I went into the treatment during radiation. Like I said, I didn't have any idea. I had some background in radiation. I'm a trained mechanical engineering. I worked in nuclear engineering for some time. So I had studied about radiation, what the process is, and not much about medical radiation, but the engineering side of it. But there ends my awareness and knowledge of radiation. I know the unit of radiation, but that's not going to help in this case. But it was, so that means this was all completely new. And like I said, the initial part was fairly smooth. I did develop some complications, but that's in the whole journey, that the radiation side was probably the least troublesome in terms of side effects and difficulties. Chemotherapy, again, I walked in without knowing much about it at all. The side effects were, I will say, probably chemo section was the worst. But again, looking back, it was manageable. Right? It is worse for 2 or 3 days, and then it is manageable. So don't get discouraged by the word chemo or what people think or what people say how difficult it is. It is difficult, not discounting that, but it is manageable because you're looking at the bigger picture. You're trying to address something bigger. So you can go through this. You can definitely handle it. In my again, the treatment, the medication, different medications have different side effects. In my case, there was no hair loss or anything. That was a positive, but I really didn't care. I was losing hair anyways, but there was no hair loss in this particular case. 2 or 3 days of difficulties, mainly nausea, fuzzy memory, and then difficulty to eat, and then bounce back to normal for a week, and the cycle continues. So after 8 cycles, you're out of it. So that's a good thing. Getting into surgery, I had this anxiety, huge anxiety about ileostomy and the back situation. And like I said, I had to do that 2 times. Right? And the second time, it's I know what to expect, but at this time, I have a better appreciation of that whole process. And in fact, I'm really amazed that we as human, humans and the medical science in particular are able to do things like this, which was not available for people maybe even 50 years back. It was they did surgery and they did not have this maybe. So compared to that, we have come a long way. The whole bypass process, the bypass system amazes me. And it's fairly straightforward. It is manageable. There is a lot of support system. There's a lot of the products that these companies make, and the nurses that are around how to manage these kind of things is amazing. Is beyond words. So that changed my perspective a lot in all those areas. What was easy and what was difficult, I think I covered most of it. Radiation and even surgery would be, I would say, the easy part. chemo was the most difficult one, but none of this is unmanageable. Don't think of it as extremely difficult and impossible to handle. You can handle it. We are stronger than what we give ourselves credit for. We will be able to handle things. One of the challenges was to support family, support Priya, support my wife during this, because I always felt that I was not doing enough to support her because I'm focusing on my own problems. So that's where the other support group comes. Make sure that you are taking care of your caregiver. Give it back. That's very important. I would like to end this by talking about looking ahead, what is in store in general across the board for any cancer treatment. Primarily after surgery and after all the treatment, radiation, chemo, and surgery. The next step is monitoring, surveillance. So they'll put you in surveillance. They're going to put me in surveillance after my reversal surgery. There'll be increased there'll be regular scans, with increased frequency in the initial days, and then that frequency kind of tapers off. There'll be regular scans and colonoscopy in my case for different types of cancers, maybe different kinds of scans and monitoring, and then that frequency, that period increases over time. And based on that. There isn't any other ongoing medication or treatment or anything other than this monitoring in colorectal, from what I understand. Maintain a healthy lifestyle in general. It's going to help you go through these kind of treatments and beyond. So maintain physical health, exercise regularly. Some of this may sound like I'm preaching, but it's very important that exercise regularly and eat healthy food. Try to avoid as much as unhealthy food as possible. Doesn't mean you should never eat chips or pizza or anything like that, but maintain good nutrients. I have a vegetarian diet. I'm a vegetarian, so it's even more important to make sure that there's enough protein intake, protein supplements, protein shakes, and things like that. That's what I resort to, because I know for a fact that my general protein intake may not be sufficient, especially during surgery or after surgery, to help body recover faster. So protein supplements are important. Meditation and mindfulness, that's mental health, taking care of mental health. And one of the ways that I cope with that is some of that meditation. The group that Ravina is running is amazing. We have meditation sessions, and not just in that session, you can practice what she's teaching outside of that on a daily basis. In today's world, pick up your phone. There's meditation apps, or several apps that are great. I do use some of them, and try to be very regular on that on a daily basis. That helps you calm down. It helps you focus, and it has a lot of explainable benefits under the covers. So maintaining a healthy lifestyle is a good next step in general, and in particular after a treatment. Support your caregiver, like to repeat myself, make sure that they are taken care of, make sure that they have enough support themselves to take care of their mental and physical health. Try to stay positive. Easier said than done, right? It is easier said than done, especially if when you're going through these difficult times. But it is possible. It is possible to keep positive. There are days when it may sound like things are really bleak, but the next day you will bounce back. So don't get disheartened by one single day, one single event. Let us set short-term goals. Let us do what you are able to accomplish today. And then once you accomplish that, feel proud. Let us celebrate, small wins. Go for a walk. You walk 1 mile, celebrate that. and things like that. Let's finish tomorrow's this event. Things like that. Small wins. Take pride in that and celebrate that. And let us have gratitude for all the good things that are coming our way. Let's have gratitude, and these things will take us a long way. With that, I'd like to end this. Thank you for your time, and thanks for a great set of sessions in this group. Thanks, Lopa.
Thank you. Thank you, Krishnan. It was really, really great. I just loved it, the way you connected the mental health and emphasized on it, because the emotions and there's a huge taboo around it, because it's the culture, and we do not speak about it, and how you connected it. And also you spoke about the positivity about the treatment and I was very touched, listening to that also, how you were thinking in a positive ground with the medical advancement and connecting it all, and emphasizing on the caregiver ground too, because it's so important. And I think we had, and I know Dr. Raghava was a speaker too last year, we had a session exclusively, honoring our caregivers. So we had caregivers as speakers, so that, because we totally understand that's so important. So thank you so much, Mr. Krishnan, for your time today, and walking us through your journey in a very detailed pathway. And this has been very helpful. Thank you, Mr. Krishnan. So I would like to now, open the session for Q&A. And before doing that, I would just make sure that we address the first few questions that came up on the chat room. And I hope, Dr. Neetu, are you still here? Because I know you had a question regarding your mother's treatment, right? So I know your mom is going through stage 4 breast cancer. You had mentioned it, yes. So Dr. Neetu's question was, I think, yes. Would you like to ask that directly, Dr. Neetu? I think you have it for Dr. Raghava. Like, do you think targeted therapy is better than chemotherapy? Dr. Raghava, would you like to take that, please?
Yes. So it depends, right? If you have a target, obviously target therapies are much better than chemotherapies. One, they're more efficient, and two, they're also better tolerable. But you have to have a target. Like I gave an example of laser-guided missile. If you know where the pocket of your enemy is, you can better target it with precision without causing much collateral damage. So the targeted therapies are still evolving. And so far, we're starting to understand some of them. Like, for example, in cancers with HNPCC, the genetic cancer, there is a defect in the repair gene. That means your body cannot repair a problem. The immunotherapy works amazingly well in that particular one. One could say that's immunotherapy, but it's also in a way targeting, because it's targeting a specific signal. So yes, it's still an evolving area. And that's why, in my view, everybody with, right now though, everybody with stage 4 cancer should have what we call a genomic sequencing of the cancer cell. I believe even stage 3 should, but we just don't have data to show that if that would change our treatment in any way.
Yes, absolutely true, Dr. Raghava. And also, just to add, Dr. Neetu, so basically here, it's very difficult to also compare the CRC targeted therapy with the breast cancer targeted therapy, where we have our own protocol to follow, and which is so much dependent upon the hormone receptor status and all of that. So definitely it is, as Dr. Raghava mentioned, so it also depends, and based on the cancer scenario and also the stage of the cancer. So thank you, Dr. Raghava, for taking the question. I would go to the next question by Mr. Mahindra. And Dr. Raghava, this is for you. Do you mean ablation is with the CO2 surgical laser ablation for ablation treatment option?
So there can be different kinds of ablations, and they're mostly surgical based. And if I recall right, the times or the chances where ablation are typically used or not so frequent. I mean, the tumor has to be really, really small. There should be absolutely no indication of it beyond the colon. It's typically used in rectal cancers more so than the colon cancers because it's easily accessible. They're typically radiofrequency ablations, but also some people have used laser ablations and cryoablations. But again, it depends really on what we're looking at in terms of what. Like in the last, say, 10 years, I probably had about 4 or 5 patients who had ablations. It's a very small number.
Mhm. Thank you, Dr. Raghava. I hope, Mr. Mahendra, you are still here and Dr. Raghava has addressed your question. So I would go to the next question from Ms. Nagavardhini. And the question is it colonoscopy procedure, does colonoscopy procedure cause any cuts or wounds? And Dr. Raghava.
Oh, no. I mean, again, any procedure can have a risk. Yes. But even a biopsy can cause perforation. But if you look at what is the risk is very low compared to the benefit that you'll get out of colonoscopy. It's very safe now. That's why I said, go to a gastroenterologist, not any other doctor who is doing colonoscopies, just because their eye for the polyps and their expertise and their experience is a lot more easier to handle.
Correct. Yes. Thank you, Dr. Raghava. And we face similar question regarding the mammogram, which is the screening, and is being asked. So it's basically weighing it, what is more important. So definitely as Dr. Raghava and the other speakers have mentioned, we have to go for a screening protocol for the CRC, irrespective, and now I would say, I think there are a lot of suggestions also in our support group, and thank you, Indu, and thank you everyone for your wonderful words for our webinar today. Thank you, Ms. Sheila, Ms. Indu, then also Ms. Wahini, Mr. Dilip, and everyone. So I would like to, I think I don't see any more questions, but more recommendations. So please go to the chat room. I've seen Mr. Jason sharing his support group's contact and also the picture of the liver. So please.
Lopa,
please
I think you have Rekha Goswami.
Yes, so now I'll go to the questions who have raised hands. So I hope I didn't miss anyone at the chat room, right? Ravina, could you please check once for me, please? And then I'll open the forum for direct Q&A. So Ms. Rekha, would you like to please unmute and ask your question to the speaker?
Dr. Lopa, this is Dr. Neetu only. It is my sister's number. My internet was gone. So
okay,
I'm using
no problem.
it. So no problem.
All right. Sure. Thank you.
Thank you for the answer. Also, I just want to ask, this is a 4th stage cancer and this is a breast cancer, correct? So I cannot compare it with the rectal that you have just mentioned, but the doctors have decided to take on the target therapy. So can I also ask them to go for the chemotherapy or something like that? Because I cannot suggest, I don't know what to ask. So that is my question.
I think even for breast cancers, there are targeted therapy options. But again, it all is so the first question to ask is, one, do I need genomic sequencing? Meaning looking at the tumor and its molecular picture to identify those targets. And of course, the target therapies in breast cancer are very different from colon cancer. So it's up to your oncologist to see which target. Sometimes you may find a target, but you may not have a medicine to target that mutation. So everybody with an advanced cancer, in my view, should have a genomic sequencing test. Both, there are 2 ways to do it. There's a blood sample, they can do it. It's not super accurate, but it is a useful test. And the tissue sample, that means the sample that they have resected or done a biopsy in the past, they can send that sample. It does not have to be a fresh sample. It can be an older sample as well. So I guess what you would ask your oncologist is, can I get genomic sequencing?
Okay, thank you very much. Thank you.
Thank you, Dr. Raghava. Yes, so I think we do not have any more questions. on the chat room, right? Right, Ms. Ravina? I think we do not. Yeah. So,
I
but
see
then
Jason's
please.
hand up.
Yes, Jason, Mr. Jason, I see your hand raised. So would you like to ask a question or say something?
I actually wanted to touch on the targeted therapy a little bit. I meant to mention that when I was talking before, and I was a little out of sorts. So I'm undergoing treatment with something called Vectibix, which targets the EFGR receptor, I think. I don't have all the science behind how that works. I don't really care the science behind how it works. I just care that it works. And in my case, the side effects from that medicine, and this is somewhat of a warning to those who do not have colon cancer, as even more of a poke to go get checked out. The side effects are that it affects your skin, right? I don't know if you can see, but my face is broken out. I have pimples all on my torso, pimples on my butt. I can show you here, see the cut on my finger, a lot of different places on my hands where there's a joint where the skin kind of folds a little bit. In between my fingers, there's a lot of irritation. I get mouth sores from that. But that drug, if you think about all the things it's doing to my skin, then you can also think about what it's doing to the tumors inside of me, right? From what I understand, and this is horrible, the worse you look, the better it's working. I actually had a 2-week break, and that's why I'm not as broken out as I was 2 weeks ago, because 2 weeks ago I could go like this and peel pieces of skin off my face, because that's what it does. It basically makes you shed the top layer or several layers of your skin. But it works. It works very, very well.
Yeah, it's a EGFR is a signal on top of the cancer cell. It's called a growth factor signal. But in order to use that, we need a test called KRAS, KRAS, and it should not be mutated. It should be clear. When it's clear, yes, Vectibix, the irony of Vectibix is, it's called panitumumab, is the more the side effects, the better it works. You're right. It's called as acne, like rash on the face, and antibiotics work to keep it under control as much as we can. But the more the rash people get, that means it's an indication that it's really working. You're right. It's an irony. We don't have a way around it as we speak.
Yeah, true.
I'll share another picture in just a moment in the chat group, and you'll get to see what it looks like when it's really bad. At least on me. You know, it may not be that bad for everybody, but for me specifically, when the rash gets to me, it's pretty rough. Hang on, let me just find the picture. Anyway, that's all I had for the moment. I just wanted to touch on that and say that it really works when you're able to take that stuff, but you do have to get all the testing that the doctor was talking about.
Yeah, no, thank you so much, Mr. Jason, for bringing it up. And I think, Dr. Raghava, we have another question from Deborah. Dear Dr. Reddy, do you collect NGS data throughout the course of patient's disease? If the answer is yes, is there a notable progression of genetic aberrations? For instance, do you see early mutations in oncogenes followed by second-generation evolution of suppressor genes? Is there any evidence for gain of function mutations in the suppressors that might suggest evolution of a cellular program that is attempting to reel in the oncogenic growth? Maybe much of this is evolving as the technology is still reasonably new and relatively expensive.
Yes, you're right. And I think you brought up a very good point. So at what point of time we do the next generation sequencing? Usually at the time of diagnosis of stage 4 or advanced disease. That's where we are as of 2022. But I'm sure in a few years from now, we'll be doing on everybody. That's one point. Second is, do we believe that that mutation is retained for the entire disease course? Unlikely. At some point, it's going to develop something called resistant mutations. So at every point of time, it will be great if we can do a biopsy and run the generation sequencing again to identify the resistant mutations to treat appropriately. But that's not financially or logistically feasible. So we we take advantage of liquid biopsy, a blood sample, to try to identify if there are any new mutations at every part of the trajectory of the cancer. But again, even that is not very feasible at every place as we speak. The third point is, yes, the costs are big. So until the costs come down, we may not be able to use as frequently as we want to. And three, I think we need more clinical trials in these ones. For example, we need a basket trial that can look at different mutations and how they evolve. And if one particular mutation was there to start with, what kind of resistant mutations actually happen when the cancer doesn't work against that particular treatment? We need a lot more research. Yes, it's still quite an evolving field.
Yeah, thank you so much, Dr. Raghava, for this answer. And I think we have another question Ms. Manisha, thank you for your kind words. And Ms. Indu, we have a question from her. One of my family members had adenoma, which was removed and biopsy done during her colonoscopy, and was asked to repeat colonoscopy in 2 years, and all was negative. And how often is colonoscopy required? That was for Dr. Reddy. Yeah. So, Dr. Raghava, would you like to take that question, please? Yeah.
Yeah, I would ideally defer to the gastroenterologist who's done the colonoscopy, because the frequency of colonoscopies depend on what kind of polyps they saw. Was it 1 polyp? Was it 3 polyps? And was there, in that adenoma, was there any cells that showed a little abnormality like hyperplastic or dysplasia, etc.? So typically speaking, if the 2-year colonoscopy is good, they generally tend to do the next one in 5 years. But again, that depends on what they saw in 2 years. So the key is to keep a follow-up with them once a year or so to make sure that they are aware of it rather than anything falling through the cracks.
Correct. And so, Dr. Raghava, adding to Ms. Indu's question, I would just like to ask also that do you think in this cases of high risk factors, or when we have a suspicion, already they have the adenoma ones, so do you think that we can do like the Cologuard every year just as a precautionary, and which is a simpler, non-invasive, and that can be like a backup for our mental peace?
I think one could say theoretically it's possible, but once you have polyp, or if there is any changes in the polyp, I think colonoscopies are much better than Cologuard. That means with Cologuards, we're just taking a risk.
Correct. No, I agree. Okay, thank you. And I'm sure Ms. Indu got her answer. And Ravina, Ms. Ravina, I see your hand raised. Do you have?
Yeah, it was just a quick question for Dr. Raghava. So Dr. In February this year, my oncologist told me that, I've been 5 years in remission, and that he probably doesn't need to see me unless I want to be seen once a year. And I just wanted to get the best possible advice on how to go about it, because I told him I would like to see him at least once a year for all my tests. And but I think he said that you're not even eligible for a colonoscopy, not a colonoscopy, or CT scans.
Personally, if you go by the guidelines, I think in a way the entire country runs on standardization.
Yeah.
And it is a part of the standardization process, weighing in the risks, benefits, the costs, everything together.
Yes.
Personally, the way I approach is I still follow them. Probably, if someone was diagnosed with stage 4, I follow them every 6 months, at least until 7 to 8 years before I switch to a yearly. Why? Mm-hmm. Because it's not about deferring it to them to recognize the symptoms, but it's the history that we use when I sit and when we talk to our patients about what grabs my attention, about, hey, you don't look like you did, or something that grabs our attention. It's a clinical acumen that years of going through that we have, that gives that stimulus to say, do I need to check something on this person? And so that's basic. I tell my patients, if I go by the guidelines, I don't have to, but this is what I personally feel. And second, as for the scans, for stage 4 cancer, I still do a scan up to 10 years, once a year. Why? Because I don't want to wait until a patient comes to me and say, I'm having abdominal pain. Now we are 5 steps behind. So yes, it's more of an insurance thing because it's cost. But how can you put a cost to a life of a patient? So I generally, that's my perception. People could argue with me, and that's okay. But
I've already been at like once a year for the last 2 years. And when I hit the 5-year mark, he said, you can come in. I won't be able to do CT scans, but maybe we can do your tests and markers and everything if you want to once a year. And I was like, if I can't afford it, I'll go to India and get it done. But I just don't know because I honestly, I know they say you're exposing yourself to, the scans, the radiation, but I've been through so much. I would rather do that.
Yeah, the risk is very low. And usually I tell them, if you tell the insurance, I hope there's nobody from insurance on this meeting, but I usually say, my person is having abdominal pain and do I do the scan? Yes, I'm cheating the system a little bit, but I think it's really important for that person to make sure that their concerns are addressed and they're well taken care of, as opposed to just going by the guidelines. Guidelines could be very different from someone who is 50 years old to someone who is 80 years old.
Exactly.
So, but guidelines are the same for all of them. But in real,
and that's what I feel like. We shouldn't be treated like a statistic. It's an individual case-to-case situation, and I truly feel like at least once a year I do need that. Just for my own, even if it's just for my own mental peace, but I would need that. So I'm not sure how to approach this.
I'll give a small analogy. If a termite guy comes in and say, hey, if you want, I'll do the inspection for you after 5 years. I'll say, I don't know about termites. I don't know when they'll come. I want you to tell me if I need it or not. That's basically where it comes back to, I feel.
Absolutely. Thank you. I will be taking your guidance quite seriously on this. Thank you.
Thank you, Dr. Raghava. And yes, Ravina, we say that to our breast cancer patients too. Even though it's a clear cheat, we need to be on top of it. Yes. Thank you.
I'll be going into him for abdominal pain. I know that.
Mr. Krishnan, do you have a question? Because I see your hand raised.
Yes, I was going to ask Dr. Raghava a question. Like I said when I was talking, the follow-up in my particular case, so specific to my case, so bear with me if I'm going too deep into my case. When the surgery was done, the surgeon came back and said that he believes he got everything out. And then they have a tumor board where they discuss each case. And then after that discussion, they came back and told, both the surgeon and the oncologist came back and told that they are not proposing any follow-up treatment like chemo or anything, because they believe they got everything, and the next step is surveillance. So I'm not sure if it is pretty standard, or is it more common to have a follow-up chemotherapy or not after surgery?
You mean to say after you finished your chemotherapy, should we do more chemotherapy?
Well, I had radiation. My sequence was like this. I had radiation treatment, chemotherapy, and the first surgery, and an ileostomy reversal. And then in a scan, they found a mass. So I had another surgery.
I see. And again, it depends on where it was. And personally, if that was the only place that was taken out, we tend to wait. And I would probably do more aggressive scans. I would do maybe 3 scans a year as opposed to 2 scans a year, because this is my experience. If a cancer comes back, it tends to come back within the first 2 years from the time you had your treatment. If it doesn't come back in 2 years, it's not impossible, but the likelihood of it drops significantly. So I tell my patients that during the first 2 years, I'm going to scan more often than what the guidelines suggest, because I know this is my opportunity to catch it as quickly as I can. Beyond 2 years, we can relax. So in someone like, if it's a single place coming back, surgery is done, taken care of, I don't give more chemo because, chemo causes more side effects and we might be developing some resistant mutations as well. So we tend to say, okay, let's wait, but scan more aggressively. If it comes back, then yes, chemo would be on the order.
Thank you.
Mhm.
Thank you, Dr. Raghava. So I think we don't have any more questions, and because we definitely, it's been 2.5 hours from our 1-hour webinar. So it was wonderful actually. And everyone stayed back till we completed all the speaker sessions, and and those who had questions, they stayed back for the Q&A. So saying that, I think we don't have any more questions. So is it okay, Ravina, Krishnan, Jason, and Dr. Raghava to give the vote of thanks and close the webinar today?
Yes.
One thing I need to say,
Yes.
next year, you probably have to do half a day or a full day workshop for colon cancer.
I know. No, this is.
I'm sure we're going to grow too. So
yeah. So this is wonderful, and it's going to reach globally, because it's recorded, and this will be so helpful, because that's what I do. When anyone reaches out to me with a CRC, I immediately send the YouTube links, which really, really is helpful. And that's the reason why, it is not like just for today, it's forever that we are going to have it. And saying that, I would like to end the session by thanking our speakers, because of your time today. I know, Dr. Raghava, you had a lot on your plate, and still you accepted our invitation. I'm so grateful on behalf of CRC and on behalf of Ravina. Thank you, Ms. Ravina, Mr. Krishnan, and Mr. Jason. I think what you did today is phenomenal, because you shared your story, your journey, which is not easy. I totally understand that, but you did it for others fighting cancer and for our community, so that you can advocate for early detection screening, which is so important, because even in the US, in Charlotte, I know those who are 45 plus, and they are in my friend circle, but hardly 2% might have gone for screening, even though I keep saying that to them. So this is so important, and that's the reason advocacy from a CRC advocate does the magic. That's so powerful. So thank you so much for doing this, and I think I should be very thankful to those who stayed back and till the end, and on the Sunday morning or Sunday evening, depending upon the time zone. And thank you so much. And with that, I would like to formally end the webinar today with gratitude to each of you for listening to us all throughout. And the most important part is, please carry this message forward, because it should work as a ripple effect. Please share this information so that everyone in your circle goes for the CRC screening. If they're fighting CRC, connect them with us, because we are always here for you. Thank you so much.
You're
Thank
welcome.
you.
Thank you for organizing.
Thank you.
you.
Bye.
Bye-bye.